Hello again, everyone. I'm very happy to be presenting this topic today on obstetric violence in the Eastern Mediterranean region. So as mentioned, my name is Merette. I'm based here in Cairo, Egypt. And really, it's my truest honor and privilege to be joining this very timely advocacy on reproductive justice, especially in light of what's happening in the States now with Roe v. Wade and all of the ripple effects that it will have globally, and in light of the advocacy that is currently ongoing here in Egypt for women's rights and women's empowerment. So a little bit about me, you can scan the QR code here to access my LinkedIn. Would be very happy to connect with anyone. As mentioned, my name is Merette. I'm the founder and CEO of Your Egyptian Doula. You can contact us via any of the platforms via our website, www.youregyptiandoula.com, and we are also live on all social media platforms at Your Egyptian Doula. In addition to being a birth worker, and one of the few birth workers here in Cairo, Egypt, Your Egyptian Doula is very proud to be one of the first doula organizations in Egypt and in the region. So in addition to being a birth worker, I'm a childbirth doula and a birth educator. I'm also a health systems researcher. My background is actually in public health and in health systems research. And it's my truest honor to be able to combine this grassroots level work and hands-on work with clients. And it's really, as any birth worker will tell you, the deepest honor that we have to hold that space and empower women and families during this journey of becoming parents. It's a huge, huge, huge milestone, of course. And for us, a true honor to advocate for you and hold, that very beautiful space. So for me, I hold the honor of holding that grassroots lens and being able to work with families, but as well as being a health systems researcher working at the global health level. So looking more broadly and more of a bird's eye view from the health systems level. So let me tell you a little bit about how we're going to conduct our session today. I'm going to introduce you to the Eastern Mediterranean region. From there, I'm going to talk a little bit about my research on obstetric violence in the Eastern Mediterranean. I'm going to zoom in a little bit to give you an overview of what's happening here in Egypt and outline obstetric violence here in Egypt. From there, we're going to talk a little bit about how are we eliminating obstetric violence? What are some things that we can do, whether at the individual level, community level, policy level, etc. And through discussing some of these recommendations, I'm also going to share with you a little bit on our project that Your Egyptian Doula has recently conducted, titled Shared Decision Making for Respectful Maternal Care, where we offer this tool of shared decision making as one of the recommendations in mitigating obstetric violence. And of course, we'll close out the session with a Q&A. So if you have any questions, feel free to put them in the chat or ask them at the end of our session. Okay, so let me tell you a little bit about the Eastern Mediterranean region. Of course, geopolitics globally are very tricky, and every entity, every organization, the different players divide the regions differently. So many of you may have heard already of the MENA region, so Middle East and North Africa. Some of you call it just North Africa. Some other folks call it the Arab states. Some of it call it Eastern Asian region, different terminologies for different things. We go by the WHO, the World Health Organization's geopolitical division, which is the Eastern Mediterranean region. As you can see from this map, the Eastern Mediterranean region covers 22 countries from Morocco to Pakistan. Of course, as you can see from this map, and as you well know, there are very, very, very different health systems as part of this region. Highly diverse health systems ranging from fragile and conflict-affected countries, Afghanistan, Somalia, Iraq, Syria, Sudan even, ranging to some of the wealthiest countries in the world, including Saudi Arabia, the Emirates, Oman, etc. So of course, when we look at a very bird's eye view or broad picture of the region, we're talking about very, very different systems and very different contexts in which women are birthing. And let me also preface by saying here, I will be using women in an inclusive manner. But for the purposes of this presentation, I will be referring as birthing people as women. In the Eastern Mediterranean region, there are very wide ranges in terms of some of the reproductive indicators, reproductive health indicators. So taking one example, let's look at fertility rates. Here we're talking about 1.5, and again, these are rates, so bear with me here. These might not be super logical when we're talking about 0.5 children, but again, speaking more broadly in terms of fertility rates, we're looking at 1.5 children per woman in the UAE. That is the smallest of the range, to 6.5 children per woman in Somalia. When we look at the region, 1/5 of the population of the region are adolescents, and adolescent fertility rates are also quite high, with a very, very wide range. Further information can be found in the references of the slide. In addition to that, going a little bit beyond the data, let's talk a little bit about the culture. Let's talk about the different dynamics in which sexual and reproductive health and rights are discussed in the region. The region is characterized by, generally, to be fair, generally a culture of silence and stigmatization around sexual reproductive health and rights topics. Here we're talking about high prevalences of taboos. Certain things are maybe not so openly discussed. And this is due to, again, a very widespread culture, maybe patriarchal culture, that influences what is normalized, what's not normalized, what's tabooed, what's not tabooed. And of course, this is not unique to the Eastern Mediterranean region, but this is quite common across many more culturally conservative regions or settings. To give you a little bit of a background about why we started conducting this research. So I will also preface this by saying the obstetric violence in the Eastern Mediterranean region was an extensive research that was conducted as part of a master's thesis. And from there, various outputs, including publications and webinars, have come out of this. So where did we start? And also to preface, I should have mentioned this in the introduction, Your Egyptian Doula, our mandate, or the reason why we exist, is to advocate for the elimination of obstetric violence here in Egypt and also regionally. In addition, of course, to the different areas of service delivery which we work on. So why did we get started on this? So in 2009, there was a lot of political momentum at the UN and WHO level to talk about obstetric violence. This was the first time that the topic of, or the issue of obstetric violence was presented by the UN Commissioner for Human Rights on gender-based violence. This was raised at the highest level of the United Nations in the fora to discuss human rights and development and how countries should address this issue. This was a big deal because from there, WHO pushed forward various researches on this topic of mistreatment of women. And in 2019, it was the first time that really WHO took hold of this subject and started putting out different guidances and different researches. And again, these can be found in the references of this PowerPoint. Initially, what started this conversation is two phenomenal researchers, Bowser and Hill, who started a landscape analysis in 2010 to discuss the mistreatment of women in childbirth. From there, much momentum has been built to really deep dive into this topic and figure out how are women experiencing childbirth? What is this widespread mistreatment, the disrespect and abuse that women face while giving birth, and really at a more systematic level or a more structural level, what is this very widespread form of gender-based violence that is occurring across various health systems? It's not only a Western issue, it's not only an Eastern issue, it's not a wealthy country issue, it's not a developing country issue. In Egypt, obstetric violence is common. Across the Eastern Mediterranean region, obstetric violence is common. And as your host country in the United States, obstetric violence is common. Obstetric violence is not something that correlates to income, and we will discuss this a little bit further in this presentation. What we found in an initial scoping review is that women's voices are not sufficiently captured in the literature. This is especially the case in the Eastern Mediterranean region. There's very few there's limited research on obstetric violence in the Eastern Mediterranean region. The topic of obstetric violence in the global research is actually quite underreported. Part of this is because it's a rather new topic. If you think about it, 2019, so it feels like a long time ago with the pandemic, but this was only a couple of years ago that this topic really started becoming more pronounced in the literature. For the Eastern Mediterranean region and for us here in Egypt, This was particularly timely given the Me Too movement that had sparked and is continuing and is ongoing here in Egypt and as well as in the region. Finally, the Eastern Mediterranean region, unfortunately, ranks second worst in terms of reproductive, maternal, and child health globally. And so when we talk about obstetric violence, this is the context in which we are discussing it and visualizing it and trying to eliminate and eradicate it. So the objective of our study was to provide an overview of obstetric violence in the Eastern Mediterranean region from a feminist perspective, from the lens of women's voices. The objective of the study was always and will forever be in our advocacy and research to center women's voices. So here we're looking at experiences and narratives of birthing women and using these experiences of disrespect, abuse, mistreatment, obstetric violence to offer recommendations on improving respectful maternal care in the region. So let's talk a little bit about what is obstetric violence and where does it show up. Obstetric violence is a form of gender-based violence. It's structurally embedded at the intersection of health systems and society. One of the reasons that makes it so difficult to see is because of its embeddedness in these much larger systems. Often, obstetric violence is normalized by sociocultural norms, and I'm sure this was covered in many different presentations today. The big problem that we're facing is that this has become normalized. Over medicalization and these types of violence are normal. They're not. Recent studies have found that 1 in 3 women globally experience birth trauma. And this is a huge problem when you think about it. Global data on obstetric violence is quite varied, as others may have mentioned already, ranging from 12 to 98% in a global study conducted by WHO. And the reason for this wide range is because it's actually quite subjective. How women report, what are the factors that maybe limit women from reporting. And as we know, with all forms of gender-based violence, there are very high rates of underreporting. We're only seeing a little bit, the tip of the iceberg. What we also know is over the last couple of years with the pandemic, the prevalence of obstetric violence has increased. Looking a little bit narrowly or zooming in a little bit to the Eastern Mediterranean region, what we found in the study is that obstetric violence is prevalent in the Eastern Mediterranean region with every type of disrespect and abuse found across health systems, regardless of country income or regardless of health system fragility or strength. And what this means is that every country in the region, ranging from, for example, Afghanistan to Saudi Arabia, maybe one of the poorest and more fragile health systems to maybe one of the more secure and stable health systems, women are facing obstetric violence. What the study found is also that 6 out of the 7 types of obstetric violence or disrespect and abuse were found in almost 2/3 of countries included in the study. And we'll talk in a little bit more detail about these typologies and the countries included in the study. But just to give you an overview of what we're talking about and the overall preferences. Why is this a problem? Why is obstetric violence a problem? And why is obstetric violence in the EMR, in the region, a problem? Of course, as we talked about, the major issue here is that obstetric violence is becoming normalized. We are normalizing abuse as the standard of intrapartum or maternal care. Women are going to the hospital to have children, to have their babies, to birth, expecting trauma, expecting a worst case scenario, expecting that, oh, if I get out of here and I'm okay and my baby's okay, I guess that's fine. I guess that's the win. And this should not be the standard high quality care that we talk about when we talk about the right to health and high quality care that is provided by health systems. In addition to that, let's talk about the implications at 3 different levels. Let's talk about the implication at the community level, at the health system level, and at the policy level. At the community level, we're talking about continued underreporting and the failure to recognize abuse by women and their communities. And of course, this has ripple effects. At the health system level, we're talking about the continuation of abusive and non-evidence-based practices by healthcare workers and the health system. When we talk about the right to health, we also need to talk about women's rights as part of this intrapartum care. At the policy level, we need to talk about the general acceptance and passivity towards human rights violations by policymakers who are continually closing their eyes or turning a blind eye towards this gender-based violence that is embedded within systems. So to put us all on the same page, I'd like to briefly explain to you this conceptual framework. So here, as mentioned, we talked about obstetric violence existing at the intersection of sociocultural norms and health systems. Within health systems, we're talking about providing high quality maternal care. As part of providing high quality maternal care, which again, there are different ways of explaining this, but to be very, very simple, what we're talking about here is evidence-based care. And of course, we can talk about the 6 dimensions of quality of care. But to put it simply, evidence-based care, while also providing this care with dignity and respect for every person entering the health system. So when we're talking about high quality of maternal care, we also need to keep in mind that respectful maternal care is a part of that. Respect and dignity are essential. Rights-based care is essential to providing high quality of care. Going one level in, when we talk about obstetric violence here, I'm talking about the last 2 circles in these concentric circles. For the purpose of this presentation and of this research, we use the Bowser and Hill framework, and I'll talk about this in one moment. The 7 categories of disrespect and abuse as a proxy for obstetric violence and capturing obstetric violence in the region. So as you can see, that inner circle, it's completely covered by that band of obstetric violence. And what happens here is that it's not just the disrespect and abuse that occurs, but we're talking about non-evidence-based care that's being violated, disrespectful care, lack of respectful maternal care, lack of quality of care. All of these are a part of obstetric violence. At the intersection, normalized, embedded within the health system and normalized by sociocultural norms. To give you a quick overview of our methods, we conducted a scoping review given the limited empirical literature on the subject in the region specifically. And what we found was that, as you can see from the Prisma chart, only 38 articles met the inclusion criteria that again focused on women's experiences and how they have experienced obstetric violence in the region. 90% of these articles were peer-reviewed publications. 4 were included due to their relevance and newness of the topic, perhaps from different perspectives, whether it was a thesis or a blog post written by different providers. Most of the articles included were from 2017 to 2019. Most articles were set in public urban hospitals. And again, keep in mind the Eastern Mediterranean region is quite vast and quite diverse in its health systems. Of the countries included in the Eastern Mediterranean region, about 15 of the 22 countries were represented in the literature of included articles, and half of the countries in the region, we were able to find country-specific narratives, articles, evidence. What we found from the findings is that really there was not a geographical bias in the articles. There was not a country-specific bias either. Of course, the articles were not evenly represented across the high, low, and middle income countries. And again, reference to this can be found at the end of this presentation in the links. So the thematic analysis and the analytical framework that we used, as previously mentioned, we used the Bowser and Hill model, the 7 categories of disrespect and abuse. And what we found is for each of these 7 categories of disrespect and abuse, various sub-themes were identified in the literature. To put it broadly, obstetric violence in the Eastern Mediterranean region was expressed through the provision of hierarchical, technocratic, over-medicalized care, with routine interventions often pushed on women in a manner that is too much too soon, again, going back to the lack of evidence-based practice, without their consent. As you can see from the 2 bolded and white font in this table, the 2 most commonly found types of disrespect and abuse in the EMR were physical abuse, specifically the overuse of routine interventions, going back to the point we raised on over-medicalization, as well as non-dignified care. Whether this looked like verbal abuse or dehumanized care, or women feeling as though they were neglected in care. In addition to these 7 categories, and as you can see from the evidence, we actually just published a paper outlining each of these 7 categories of disrespect and abuse, and offering the different types and examples from women's voices and women's narratives for each of these areas. And reference again can be, the reference can be found in the later part of this presentation. In addition to these 7 areas, we also looked at other enabling factors at the personal level, the health system level, and the socio-cultural level. Again, when we talk about obstetric violence, it's very important to keep in mind that we're talking about a form of violence that's embedded in the health system and normalized by socio-cultural norms. So the way people perceive dignity, the way people perceive respect, of course, will impact their perception of whether or not this care was non-dignified or confidential or consented, of course. Further to that, when we talk about the Eastern Mediterranean region and different health systems that exist, we also need to talk about what are the barriers and limitations at the health system level that maybe enable this normalization of obstetric violence. Of course, this is not justifying this form of violence, but looking more at how is this becoming routine in many cases. So, diving a little bit deeper, what we looked at in this study is the different categories of disrespect and abuse, their corresponding human rights, and as found in the study, what are the different forms that came out of this. So as you'll see here, the 3 most prominent ones were physical abuse, the overuse of routine interventions, non-consented care, specifically unconsented overused routine interventions. And again, the lines between these types of abuses are not very defined. It's very often, and what we found, and I'm sure this was mentioned by other presenters, is that actually it's a compounding effect. It's not a checklist. We're not checking, oh, there was a routine episiotomy that was conducted, so this is a form of obstetric violence. Not at all. Usually with one form of abuse or one form of obstetric violence, others can also be found and are compounded. So again, physical abuse, non-consented care, and non-dignified care were the 3 most commonly found types of obstetric violence in the region. From there, I want to zoom in a little bit to talk about Egypt and obstetric violence here. Obstetric violence is widespread in Egypt. One of the big issues here is that, as per many forms of violence and gender-based violence, this is still quite underreported. As we mentioned, the implications of obstetric violence at the community level, people maybe are not very aware of, oh, this was obstetric violence. So many women may even talk about these types of abuses, but they will refuse to name this or recognize this as obstetric violence. In addition to that, this topic is new in the empirical literature. It's under-researched, and so it's difficult often to make the case for, actually, we have data to support this because it's quite few and far between. So looking at the case for Egypt, I want to talk about 3 areas. So first, some of the health system challenges to give you an overview of the maternal health system here. The second, I want to talk about the C-section epidemic that we're having here in Egypt, and of course, the implications of that on over-medicalization of birth. And finally, I want to talk about the issue of informed consent within the much bigger context of the global discussions and global limitations that we're having on the issue of consent and autonomy in sexual and reproductive health and rights. The Egyptian maternal health care system. So a couple of these statistics might shock you, but these are some of the building blocks that maybe enable some of the normalization that we talk about when we talk about obstetric violence in Egypt as well as in the region. And of course, I need to preface this by saying that every country experience and every woman's experience is different, but this is some attempt to really showcase that there is a bigger problem that's happening here at the system level that must be addressed at the system and policy level. In Egypt, 90% of deliveries are at the hands of medical doctors. Keep in mind, medical doctors Here, we're talking about obstetricians that are trained surgeons. In Egypt, the cadre of nurse midwives is not legally recognized. Midwives cannot independently practice. And of course, this has implications on over medicalization of birth in Egypt. In addition to that, and as previously mentioned, there are very few doulas. Doulas are a new concept in the maternal medical system here. And often there's a little bit of pushback from medical providers about inviting this additional advocate into the birth space. This is not a problem that is unique in Egypt, and as someone who has attended births in Egypt as well as in the US, I've seen this in both contexts, and I'm sure that folks in all settings can attest to this as well. In addition to that, when we talk about the health workforce here in Egypt, there is a huge underutilization of nurses and their capacities here in Egypt. Often nurses may be considered as support staff or cleaners or doing quite menial jobs. And at the health system level, this is an underutilized asset and resource. The broad and cross-cutting issue at the health system level here in Egypt is that there is very limited women-centered care, whether this is in maternal health, whether this in sexual reproductive health more broadly. And of course, some of these values and some of these elements of women-centered care will mitigate the high prevalence of obstetric violence in Egypt and of course regionally. In Egypt, 72% of obstetricians are male. Many birthing people perceive male obstetricians as the better of the two, which is an interesting perception. Around half of women have also, according to one study, believe that the presence of a female doctor is a must. So you have this dichotomy of women maybe opting to go for male obstetricians because they perceive them as better, while on the other hand, many women also prefer to have a female doctor due to some of these cultural elements. So an essential aspect of culturally competent care. 60% of deliveries in Egypt occur in the private sector. Here, we need to also note that there are weaker regulations than private sector as per many countries. And in the private sector, there are also higher rates of medical interventions. It's also important to note that while there are different aspects that are changing in terms of health insurance in Egypt, health insurance is still an area that must be improved to cover all women. Now, Egypt is unique for many reasons, but really one of the things that we have unfortunately become quite well known for is the very high C-section rates. There is a C-section epidemic that is happening in Egypt. 2/3 of Egyptian babies are born via C-section. Egypt is the third highest globally. I think we're second to Brazil and Turkey. And with the pandemic, this number has actually increased, the numbers that I'm going to talk about. So according to reported data that can be found, our current C-section rates are between 52 and 62%, which is very high. It's 6 times higher than the WHO recommendation, which is between 10 to 15%. So when we talk about this being a health systems problem, look at it from this lens. 2/3 of Egyptian babies are entering the world via surgery. The other slightly scary number that we look at here is that over a 5-year period, the C-section rate doubled. So when we look at data, according to one study that looked at the DHS data over this period of time, from 2008 or 2009 to 2014, the C-section rate doubled from 27 to 52%. And the reason I'm asterisking most of these numbers is that these are according to specific studies and different studies, and these are the reported available numbers. Realistically, and from what I've heard from my peers working in the field, obstetricians, doulas, and birthing women, actually this number is much higher. Colloquially speaking, this number is actually as high as 9 out of 10 women, so almost 80 to 90% of Egyptian women undergo C-sections. And again, the other issue that we want to look at, just to keep this intersectional lens in mind, and again, I wish that there was more data on this. This is something that really we need to work on. The issue is that C-section rates have increased 14.5 times among poor Egyptian women as compared to only 5 times among rich Egyptian women. And this number we look at from a 20-year spectrum. Of course, when we look at the enabling factors, we talk about this from both a supply side as well as a demand side. One study found that when asking about what makes this C-section rate so high in Egypt, only 31% of doctors suggested that it was due to elective reasons, as compared to 60% of women who reported that they actually chose to have a C-section or scheduled the C-section themselves. So again, the issue of supply and demand is an important one to keep in mind. Outside of this over-medicalization that's leading to very high rates of C-sections, it's also important to note that this over-medicalization and this overuse of routine interventions, often in an unconsented manner, are other manifestations of obstetric violence in Egypt as well as in the region. This is taken from a study looking at Egypt, and you can see the reference here in this book that just came out earlier this year, Obstetric Violence, the Realities and Resistance from Around the World. There's one chapter from Egypt, and this is the question that was taken from the study. What we found is that routine interventions are unfortunately quite commonly used, and they're quite commonly used in an unconsented manner. One example of this is the routine use of episiotomies. It's important to note that episiotomies, routine episiotomies, especially for first-time moms, is not recommended by the WHO. This was a recommendation in much earlier guidance, but all guidance that's coming out of WHO in the last 10, 15 years does not recommend the routine use of episiotomies. These are findings that I'm going to share with you from 2 different types of studies, just to triangulate a little bit. Again, as mentioned, we're trying as much as possible to extract data. And again, this is a highly under-researched area. One study of 42 women found that about 43% of them had C-sections, and around a third of them underwent an episiotomy. Another study found, and this data is taken from 2019, another study that was conducted in 2021, just last year, found that women had also reported vaginal tightening after episiotomies. And this was about 7.4% of women who in the study, and the study had about 1,200 respondents. 55% of them were first-time moms, and 46% of these women who experienced vaginal tightening reported this as a form of obstetric violence. They felt violated and reported this. In addition to these unconsented and routine interventions, it's also important to note that there are other forms of obstetric violence that occur in the Egyptian medical system. Women reported verbal violence, as mentioned before. The issue of non-dignified care manifested through verbal abuse. We see it again here. And also the issue of neglect. We see that health workers did not answer questions, did not provide information, and women felt neglected. But what I really would like to draw your attention to is this graphic. And again, as mentioned, this was a study that was conducted jointly between your Egyptian Doula and Al-Hubb Saqafa, Love Matters Arabic, and presented in a webinar, which again, the link for this you can find in the references of the slide. When asking women if their healthcare worker explained any changes in their medical procedure and asked for their consent, 50%, 49.5, 50% of women said no. This highlights the issue of non-consented care as a form of obstetric violence in the Egyptian medical system, and one that we found to be particularly prominent and troubling. Looking more deeply into the issue of consent and decision-making autonomy. In Egypt, outside of birth, the issue of reproductive autonomy is one that requires further study. When we talk about the decision-making power, and we mentioned this earlier in the conversation, decision-making power in Egypt and in much of the EMR, and again, this is quite a generalized statement, but important to keep in mind, is in the hands of males. whether this is a spouse, whether this is a religious person, whether this is a medical provider. So really, it's important to talk about these aspects of autonomy when we talk about consent in childbirth as well. One of the other issues that we found in this research is the high level of information and power asymmetry. Hierarchy in birth was prominent. Women reported this when they were talking about their mistreatment, their disrespect, their feeling powerless in childbirth. As you can see from this quote, the issue of non-consented care, as it also relates to non-dignified care and physical abuse, the interconnectedness of these different types of obstetric violence is seen. One woman said, they injected me with some stuff and I didn't realize I had given birth. Another woman said they refused to remove their hand from my vagina during contractions and I had very painful examinations. These are just two narratives among many for women that are unfortunately being abused by the health system during their birth. Your Egyptian doula conducted a study in response to this to try to see what are some of the ways that we can start tackling obstetric violence in the Egyptian medical system and also explore this issue of consent. So scholars, especially on respectful maternal care, have often talked about the importance of shared decision-making and the role that doulas hold in maybe neutralizing this information and power asymmetry. This is a tool that we often use as birth workers in these spaces. How do we create a space for shared decision-making to occur as a way to really equip and enable birthing people in their experience? So we conducted a study titled Rahimi, Respectful Abuse-Free Humanized Motherhood Through Youth Empowerment, where we explored this concept of shared decision-making as a potential tool to move forward respectful maternal care in this context. And what we found from this is that actually we modified the L1 and all model, as you can see from the figure on the right, on the left. And here we use this model because of its simplicity. Shared decision-making through 3 steps, looking at 3 types of players. Looking at team talk, who is the team? Who are the players? Talking about options, what are my options in terms of the position of birth, the place of birth, the type of support, the type of interventions. And finally, the third layer or the third question is related to the decision itself as well as the consent. So what we try to do here is create tips and actionable interventions for each of these 3 players. So the medical providers, the birthing person, and the family and the support. And as mentioned here, the role of partners and the role of support people and the role of family is very important in the Egyptian context as well as in many countries in the EMR. And what we found here is that it's important to have a supportive team. It's important to have researched and informed options to be able to make an informed decision. And it's important to be able to discuss consent and discuss the decision within these 3 players. The outputs of this Rahimi project were multifold. As you can see here, we created a tip sheet for the different types of providers. We launched a social media campaign, which you can access on our social media platforms at Your Egyptian Doula. If you scan this QR code, you can also find the tip sheets, the policy paper that we wrote on shared decision-making in Egypt. You can also access a video that we created about women's rights in birth. And in addition to a fact sheet on obstetric violence, which summarizes many of the findings that we shared with you today. Finally, when we closed out this project, we had a great regional webinar, which again highlighted the different forms of obstetric violence regionally in the Egyptian context, and then invited young people to discuss what is the role of youth in mitigating obstetric violence. And you can access this link through this QR code. To be respectful of time, this is a video that we wrote, that we produced as part of our campaign, which you can access. The video is in Egyptian colloquial Arabic with English subtitles. So feel free to check that out using the link. From there, I also want to take one step further. So we talked about shared decision-making as one solution to mitigate obstetric violence. neutralizing the playing field and really creating that space for conversation, for autonomy, for the right to consent, the right to have high quality care. Looking a little bit more broadly, so taking a step back and looking at what are the recommendations for research, for practice, and for policy. So here I want to just share a couple of different interventions. And again, these are detailed in the recent publication that just came out. So at the research level, we need more data. We need more findings, qualitative findings, quantitative findings. We need to measure the cost of trauma. When we're talking about 1 in 3 globally, women experiencing birth trauma, what is the cost of that? What does that mean? What are the implications of that? So really further research is needed and urgently so. In terms of practice, at the individual level, there's a very urgent need for education, for awareness, for empowerment, and to stop normalizing obstetric violence. Here in Egypt, we use the word aidi, normal. It's normal for you to experience pain in childbirth, to experience a provider insulting you or speaking to you poorly. And it's so critical that we start at this level, at the individual level, at the community level, to stop normalizing obstetric violence. At the health system and the facility level, it's critical that we invest in midwives, in doulas, in multidisciplinary teams. It's important to sensitize and train these teams on the rights-based approach and on respectful maternal care, on the principles of women-centered care. And this is crucial to ending the stigma on SRHR. It's not fine for persons to be approaching their obstetrician feeling shy and feeling like they're going to be stigmatized for discussing things openly. In addition to that, very practical interventions. We need to start investing in birth centers. We need to follow the recommendations of WHO and the evidence-based guidelines. It's not acceptable for routine episiotomies to no longer be a recommendation by WHO, but to continue to be practiced as the norm in this system. And of course, we need accountability mechanisms for women as well as for providers to report and to report these abuses and injustices. At the policy level, we need advocacy, we need action, and we need accountability. With that, I would like to give you these references. You can access all of our research on youregyptiandoula.com. This has our research portfolio. You can see here the paper that just came out literally just last week on exposing obstetric violence in the Eastern Mediterranean region, which was summarized throughout this talk. Please feel free to check that out. And in addition to that, some of the references that we used for this presentation you can access on here. With that, I'd like to thank you for your time and open the floor for questions. I'll go ahead and put my QR code back on the screen should anybody want to access that.
Merette, let me thank you for the terrific talk. And again, I hope many take advantage of listening to it on YouTube and things. Let me urge those of you who are participating, please post any questions you have in the Q&A, and we'll address those. I do have, first of all, I apologize for the introduction. That was one of my worst moments, but we'll talk about that another time. But what's fascinating me about it is looking at what the motivations for abuse are. And one of the things that strikes me is, at least certainly in the United States, is the economic motivations. And, the question of to what extent are there economic motivations for additional procedures, for C-sections, and so on. And I'd like to get, your views on that. One thing struck me is the number of poor women that you cited in the statistics, which makes me wonder, to what extent, as you pointed out, the insurance industry, plays a role in this. But I'd like to get your view on what the economic motivations for the abuse are, other than the known cultural motivations, social motivations, et cetera.
Absolutely. This is a very tricky question, and thank you for raising it. So like we said, when we talk about obstetric violence, some of the enabling factors for this is both the demand and the supply side. And again, we mentioned some of these issues from the demand side, from the birthing people side, whether this is stigma I am too afraid or too worried to have a vaginal birth out of fear of divorce or out of fear of pain or out of fear of different reasons. And so, as we mentioned in the study, one study found that actually 60% of women are electing to go for C-sections. On the other hand, there, as also previously mentioned, we mentioned in this study that about 60% of deliveries are occurring in the private sector. We need to also remember that insurance in Egypt is not very accessible. I think the latest number that was reported, and this number is a bit outdated, but this is what's available. It's actually only 8% of women of reproductive age are covered by public insurance. So here you're talking about a huge financial cost for women that they are having to pay during deliveries, especially women that, again, 60% are delivering in the private sector. In the private sector, you're not using your public insurance. You are paying all of that money out of pocket. And that really, I would say, feeds into the much bigger issue that we need to discuss in the Egyptian health system about the very high cost of out-of-pocket care. I think this number is currently at around 60% for all Egyptians. So this is not that far off when we talk about births, but it is a critical one to think about, especially when we look at the numbers for Egyptian women versus, poor Egyptian women versus more affluent Egyptian women. And when we talk about advancing universal health coverage and ensuring that people are not going into poverty, spending money on their healthcare, this is one of the issues that we do need to look at. But I mean, definitely this is an issue here in Egypt as well as in the States. The monetization and the financial incentives that providers are benefiting from the high over medicalization seen in birth.
Does your research show any difference between in terms of abuse between private hospitals, essentially, publicly or privately owned, and public or religious institutions?
Yeah, this is a tricky question. And I'll have to preface this by saying there is very little data that is available about this, but I can share from my personal experience what I've observed and what women I've worked with and providers I've worked with have shared. So again, this is more colloquial data, but I'm sure really if this was a study that was conducted, this would resonate, as I'm synthesizing the stories of many health workers that work across different areas in Egypt, so Cairo and different governorates as well. And what many see is that actually the conditions of public hospitals are very difficult. And this is true in many different health systems in the developing countries, in the MENA region, in the EMR, but also across the available literature in countries such as Ethiopia and Nigeria and many sub-Saharan African countries, where we find that the poor health systems are weak. Unfortunately, they are understaffed, they are under-equipped, they are overcrowded, and that does contribute to that definitely contributes to poor quality of care, and in a lot of ways enables some of this mistreatment. Maybe it's not overt mistreatment by healthcare providers, but again, if you're having maybe a couple of providers that are working very long shifts, very overcrowded settings, this is not a good equation to ensure high quality, respectful, rights-based care for every person entering the hospital to have their baby.
Yeah. Well, you're raising the question of the consequences of sovereign debt and the fact that most countries, again, highly indebted, tend to cut public services, among them, of course, health services. That's another issue that's fascinating. Well, one of the things that also struck me in your talk was the fact that Egypt has the third highest rate after Brazil and Turkey. What are the common features there? The only thing that strikes me is Brazil and the concern about body image, which is high.
Actually, hold on. I think let me correct that. I think it's Brazil and the Dominican Republic.
Okay, all right. Brazil then. Well, probably to some extent the same. But what are the common characteristics there that would rank them all so high?
Honestly, I have my theories, but if anybody would like to fund this research, I would be very happy to conduct this research.
I'll be happy to write your letter of recommendation on it. Go ahead.
Perfect. I appreciate it. I do think that there are many similarities in these settings. I think it would be very interesting to conduct a study across health systems and across different regions to look at that in terms of the the high rates of C-sections, the different cultural elements, the different health system elements. And again, when we talk about obstetric violence, it's like critical to drive this message that we're talking about the intersection of the health system and sociocultural norms. So for me, that would be the starting point for the comparison. How are the health systems similar? How is the culture similar? And what are the differences? I see that there's a raised hand.
Fascinating. Yeah, fascinating. Thank you. Well, no other question. Let me thank you. I thoroughly enjoyed that. In fact, I plan to show your talk to my class.
Oh, wonderful. Thank you.
Thank you very much. And I apologize again for my messy introduction.
It's all good.
But
you are very welcome to read my introduction at the end or whatever is needed to make sure that
it's far more impressive than the one I had. I will tell you that based on your presentation.
Not at all. It's my honor to be with you guys, and I really do appreciate it. And it's a very timely discussion to be having on reproductive justice and the implications it has at the different levels, whether that is at the individual level, whether that is in terms of global health policy. I think the whole world is really watching closely what's happening with the U.S. and hoping for the best.
Yeah, well, we have a public showing of the movie Birth Time later, and then a colloquium afterwards to discuss it. I'll probably bring up some of your research. So thank you.
Great, I do appreciate it very much.
Okay, well
it's
take
great
care.
Connecting with you, and thank you again for the wonderful opportunity.
No problem. Take care.
Take care. Thanks.
Bye. Thank you.